what I will talk about for the next 25 minutes is some results of the joint work with my colleague from GlaxoSmithKline, Sam Miller, who works for another department in the company. Let me quickly start through the outline. The study and the trial which I will talk about is for patients with Alzheimer's disease. So I'll talk a little bit about the background. I talk about adaptive model-based designs. You've heard about adaptive designs today quite a lot. What I will talk about is also about adaptive designs, but these adaptive designs are actually different from all of the previously mentioned. And I'll explain what I mean by this. I will talk about optimal designs, and I'll talk about adaptive approach, what we mean by that. Though, of course, there are some parallels with respect to adaptive approach. I'll talk about constrained dose selection, which is the key in this study, show you and talk a little bit about the software which I developed for this project, and talk about the alternatives models. So let me start with the background. The study is for the patients with Alzheimer's disease. You can read what Alzheimer's disease is about, some symptoms. It's really a slow degenerative disease. It becomes pronounced in the population over 60 and then becomes more and more visible, more and more pronounced. And it's really very bad, and because of the aging population, it's really a need to find treatment for this particular disease. At the moment, what we know, there is no, you cannot cure the disease. At least at this stage, there is no cure. Current treatment treats some symptoms, but they don't really cure the disease. And it's believed that what happens, plaques are formed in the brain. They attack some neuron cells, plaques or tangles, and the cognitive function of a person degenerates, and as time progresses, it degenerates substantially. So obviously there is an unmet clinical need. And again, you may have heard that 2 weeks ago there was an announcement all over the news, at least in the United States, that there was a congress, international conference on Alzheimer's disease, and there was a report about some breakthrough. And it's hoped that this particular small company has found something which really may cure the disease. On the same day, there was announcement of preliminary results of a big clinical trial of another company, and the stock of this company, because the results was negative, dropped about 10% on that day. So if you find something, it's a very big thing with respect to business. If you don't, it's you may see other kind of consequences. So, but we are talking about trying to find a cure and help the patients. So the study I'm talking about is currently going on, and GSK is holding this study. It's a multi-center, single-blind, parallel group, ascending dose study with placebo control. There is a single dose per patient in this case, and it's explained mostly by the long half-life of the compound. This drug stays for quite a while in the body of the patient. And the main goal is to evaluate safety. So safety here, it's the prime concern, because it's first time in human, and you have to start this study very, very slowly. And unlike cancer, where you assume that there should be some toxicity effect, in other therapy areas, if you have side effects, that may immediately kill the drug. So safety is really a prime issue here. But we also want to find out the efficacy profile of the drugs. We want to learn whether the drug is efficacious or not. Now, the endpoint which we have is a particular biomarker. So the study is ongoing. I cannot name this biomarker. You may find some information in the public domain, but not everything. So it's a particular biomarker. It's actually a pharmacodynamic endpoint. And the goal is to find the dose which inhibits the biomarker in plasma. And our endpoint actually will be the percentage decrease at a particular day after giving the dose compared with baseline. And this endpoint will guide dose selection. So that's what we will try to do. This plot was generated by PK modelers in the company, and it tells you what is expected from the drug. They use some animal models, and the idea is that the particular biomarker is always present in the blood, and having a lot of this biomarker is bad because it helps, in a sense, assist to produce all those tangles and all those plug in the brain. So when you give a dose of a drug, what happens, the drug, the molecule, binds with the biomarker, and the combined molecule clears from the drug, so from the body. So the inhibition increases. And then as time goes on, the body produces more and more of this biomarker, and again, the inhibition goes down. If you go a larger dose of the drug, you would expect that inhibition is larger, and so on and so forth. So this plot is with respect to time, how it goes in time. This plot is essentially the same data, but with respect to dose. And you see, and different colors correspond to different days. So the bigger dose you give, you would expect that inhibition will be larger and larger. Now, the next step will be to introduce some sort of variability. And these are results which were generated by our modelers using specialized PK software, doing some sort of compartmental analysis. And if you look at this plot, you immediately would suggest that a reasonable model for that type of behavior will be an S-shaped curve. And that's why it's kind of natural to try a Emax model, a S-shaped curve. I'll introduce the model in a minute. What time do I have? Okay. Before I introduce the model, let me quickly talk about cohort sizes and doses. So, as I said, safety is a priority because not too much is known about how the drug will behave in patients. So the subject numbers are really small here. The safety considerations is a must. So the study will start with two cohorts and 5 subjects in each cohort. 3 subjects will be on active treatment, 2 on placebo, but the initial doses will be very, very low because, and it's not expected that they will be efficacious by any means. And then we'll increase the number of subjects in subsequent cohorts. Will be 6 on active, 2 on placebo. Always there are 2 patients on placebo. This is just by the constraints of this study. It's a given. And then it's hoped that by escalation, we'll expose more subjects to the more informative doses. Doses. The initial doses, as usual, are defined using animal studies. And they are subject to limits on dose escalation because when we do this study in real life, we'll do estimation and we'll try to find doses and there will be some threshold introduced, which means small PD effect or large PD effect or vice versa here. So, and also there are also some nominal doses prescribed from the very beginning as defaults if necessary. And this is, say, the minimal dose, this is the maximal dose, and this sequence is pretty much dose escalation with evenly spaced doses, which very often is performed in first studies in humans. Now, what is the model? As I showed you the model, that's how it looks like, and that's the formal introduction of the model. We assume here that measurements are generated by some response function f with normal, identically distributed random normal independent random variables. So f is a response function. This is a Emax model with 3 parameters. Usually there is a 4th parameter, which is the response at minimal dose. But here it's expected that minimal response will be 0, so we don't have the 4th parameter. The response parameter are Emax, which is the maximal response or limit as dose increases. ED50 is a dose at which the response is half of Emax. And finally, gamma is a slope parameter, and it tells you how steep or flat the curve is. Another thing, if I bring back this plot, you see that it's obvious, and that's not what I generated. It's what PK scientists generated. That the variability in the middle seems larger than variability at the ends, which suggests that the variance should be modeled as inhomogeneous object, non-homogeneous object. And there are several ways to introduce this non-homogeneity. The variance models, we introduce 2 different models with additive and multiplicative component. The first model is when variance increases with dose, and very often with logistic models, that type of variance model is used. But here, probably our main target is that particular model, where the variance is the largest in the middle, near ED50. So formally, for this model, we have 5 parameters, 3 in the response and 2 in the variance. One of the important goals of this study is to find a dose which gives a particular response. That's what's called dose EDP, in this case, ED90. This is a dose which attains 90% of maximum response. So we will try to find this dose from the equation, and this will be a nonlinear function of unknown parameters. So the criterion which we will use will be either C optimality for this particular object or D optimality. Because we are starting, we don't know too much about the profile, so it's of interest to find all parameters of the model, and that's why D optimality is an obvious suspect here too. Now, adaptive optimal design. What we are doing is the interplay between model-based design and estimation. So optimal design was talked a lot during this conference. So we search for values of doses, which is our control variable here, that allow for best estimation, either all model parameters and D criterion, or dose ED90, which will be C criterion or linear criterion. The algorithm which we used is based on first-order optimization algorithm, often referred as Fedorov-Wynn, or maybe Fedorov-Wynn-Mitchell, because it's both adding and removing bad points from the design. So these are the classic references. And in 2007, we published a paper. It's a chapter in SAS book with a description of the algorithm, actually accurately what we're usually doing when applying that type of algorithm. Obvious problem, again, what was discussed here, it's nonlinear design. We are talking about locally optimal designs usually. We don't know the values of parameters. That's why we try to do estimation and design in parallel. For each cohort, we search for optimal doses given current parameter estimates. And this is what we call by the adaptive approach. There was a very nice survey talk by Tim just 30 minutes ago. Very nice, I think. And he talked about sequential designs and flexible designs. Keep in mind that sequential and flexible designs usually deal with normal endpoints or problems which may be reduced to normal endpoints. They don't usually have the control variable. Here we do have control variable, which is dose. And so in that sense, this approach is more closely related to what Sandra called sequential maximum likelihood, because we have, but this model is probably a little bit more complicated. But that's what we're trying to do, sequential maximum likelihood, essentially. Optimal designs. Oh, time is flying. The key, as usual, is to find the information matrix for a single observation, and the single unit of information is a patient. The formula which I present here is a general formula. There are 2 terms when variance depends on unknown parameters. And Rainer Schwabe talked about this, that there are cases when there are two terms in the information matrix. So this case, or this formula is true whether you have a simple model, single measurement per subject, fixed effect model. This formula can be applied whether you have multiple measurements per subject. This formula may be applied when you measure several endpoints, like efficacy and toxicity. This formula may be applied when you have a combination of different drugs. And there is work which is done in our group by Valery Fedorov, for example, and there are some references on that. The key is to find or approximate the information matrix. So, and if the formula looks a little bit scary, when we have a linear regression with two parameters and constant variance, this formula reduces to the formula which we all know. Optimal design. I'll just quickly flip these slides because we work and we assume this paradigm of continuous or approximate designs. First, we have to introduce the information matrix. When we have n sub I patients on a particular dose, we introduce the information matrix of the experiment. Then we say some nice words about the variance of the maximum likelihood estimator. We introduce the normalized information matrix. We introduced the normalized variance covariance matrix. And then the optimization problem that we try to solve is minimization of particular criterion. Minimization is performed with respect to designs and optimization, what we can change, the weights, which are between 0 and 1, and admissible doses. So we have to define design region. And D criterion is one of the most celebrated criterion, which you all know. But again, if we formulate problem like this, we have the dependence on theta. That's why we have to use the adaptive approach. And this is a short slide about the adaptive approach. So we address the problem of poor preliminary estimates. Next dose is chosen according to current estimates of unknown parameters. So estimation and design is performed cohort-wise. We start with some initial design because without any information, we cannot even estimate parameters. And then we add additional doses which provide the biggest improvement with respect to selected criterion, and then parameter estimates are refined, and we iterate between steps 1 and 2. And before Henry interrupts me and tells me that this is a problem where you don't have the real information matrix because we have dependent measurements, I will say it myself. It's a real problem because the doses on the next stage are selected depending on the result of the previous experiments. And the information matrix, which we call the information matrix here, this object is not the formal information matrix because information matrix, all units must be independent. And unfortunately for this problem, not too much is known from theoretical point of view. The first paper where the approach was introduced was back in the 60s, Box and Hunter, then Draper and Hunter in 67. Valery had discussion of this approach in his book. Bill Rosenberger published a paper where some theoretical results are established, but still there is no formal solution on paper, and people usually resort to doing simulations, and that's what we are doing here. And the theoretical issue, the dependence of measurements, obviously. Quickly talk about the estimation. So when we have the mean response and some variance, it's known that weighted least squares works just fine when variance is independent of unknown parameters. So that will work fine, and you will get consistent estimators. When variance depends on unknown parameters, one has to be more careful and introduce iteratively reweighted least squares. So it's an iterative procedure. It's consistent, but it's not efficient because the variance covariance matrix will be non-optimal because it doesn't take the second term of the information matrix into account. And so we published a paper with Valery a few years ago, what we called combined iteratively reweighted least squares. There is an extra term sitting here, and we proved that this combined iteratively reweighted least squares is equivalent to maximum likelihood estimator. I have some backup slides about the details, but I'm pretty much sure that I cannot show it during my talk, but I can talk about this if you have a question. And the idea here actually goes back to the famous paper by Jenrick in 1969 about general nonlinear least squares in the Annals of Mathematical Statistics. Constrained dose selection. That's the key for our particular problem. Remember that we have 2 patients on placebo for each cohort, and we have cohort-dependent design region. So for each cohort, we define in a special way, we define the maximum allowable dose for this cohort. And it will depend on the current estimates of parameters, in particular ED10, and current 6th largest dose for special reasons. We start the first 3 cohorts with fixed dose selection. Minimal, 10 times minimal, then 5 times 10 minimal. Then, after the 3rd cohort, we may start estimation and use our cohort-dependent adaptive design. So obviously, algorithm protects against aggressive dose escalation, but this is a key because it's first time in human. We don't know anything, or don't know too much about safety profile, so we have to move very, very slowly. And we may select the same dose for all patients in the cohort, or may not. So this is the option. And for this study, I wrote a MATLAB-based standalone application. A nice thing about MATLAB that you can create an executable file for essentially no price, and you can give this executable file to your customers, and they don't need to have MATLAB license. There are 2 options. One is Monte Carlo, just specify model parameters, initial design, or you can load actual data from the file and design the study for the next cohorts. How much time do I have?
Well, we have 5 minutes if you don't want too much
Okay.
discussion.
Okay. Let me quickly go. So this is just how the screen looks like. You can select the simulation option. You specify values of parameters. You specify the model of variance. You can select, there are 2 choices. You specify your criterion, whether doses are the same or not. And this is a single simulation, which makes sense just to learn what may happen. What you want to do, you of course have to run multiple simulations. We start with locally optimal design. In each case, note that we have 3 doses, 3 optimal points for 5 parameters, and by now you probably know why it may happen. We have more parameters than design points, and we don't have a singular variance-covariance matrix, by the way. Simulation option, that's how dose escalation goes. There are always placebo doses, and it's not necessarily the fastest dose escalation. That's how parameter estimates would look like. We estimate after each cohort, so it's a piecewise constant estimates, and we would expect that parameter estimates will finally at some point start to go close and close to true values of unknown parameters by the nature of adaptive algorithm. Here, after 4th cohorts, you see that our estimated curve is pretty far from the true curve, but you cannot expect anything else because all measurements are at the low end. You don't have chance to estimate AD50. You don't have a chance to estimate Emax. But if you collect more and more information, the precision improves. But what you would be interested in, of course, is to run multiple simulations and see how doses are allocated. So in this particular scenario, I had first 4 cohorts as a forced escalation. For the cohort number 5, and total number was 8. For the cohort number 5, the maximal dose was always selected. For the cohort number 6, maximum allowable was selected in most 100% of runs. And then if you look at the plot for cohort number 8, the combined weights of these clusters are close to 0.3, 0.3, and 0.4, which are the optimal weights of the locally optimal design. So that's something which you would expect from this adaptive approach. And if we calculate the efficiency of alternative designs compared to the locally the optimal, the fixed dose escalation, just more or less uniform distribution of doses, gives you about 0.53. Adaptive design, the mean is 0.61. Seems like a large loss, right? But is it a fair comparison? Probably not, because what you are doing for the adaptive design, we always have patients on placebo and very low doses, while locally optimal immediately starts from good doses closer to the right end. So it's much better to compare the adaptive design with the so-called composite design. So you have prescribed number of patients like adaptive on placebo, 8 cohorts, 2 patients in each of the 2, 3 on small doses, 6 on a little bit higher doses, and then the remaining dose you allocate with respect to composite de-optimality. And this formula is essentially like the Bayesian design. You introduce the preliminary information. Not essentially, it's actually the same formula as you build the Bayesian design. And compared to this criterion, what we see, that the efficiency of the adaptive design is close to 90%. That's the mean, and the efficiency of fixed dose escalation is close to 80%. So we quite quickly recover, using adaptive design, we recover quite a lot of information, getting efficiency of 90%. At least that's what I think. That's the estimates of EDP, and I'll probably have to skip this. One quick remark. I used the standard Emax model. There are extended Emax models. You may have seen models with 5, 6, 8, 10 parameters. Essentially, people introduce various additional nonlinearity parameter. So this particular one, there is an additional nonlinearity parameter in the denominator. So the actual ED50 is defined by this formula, and it seems that this model gives additional flexibility. The question is, does it? And for this, my colleague Sam Miller created, I think, a nice tool in Excel, very simple but very informative. So we looked at how different the 2 models are across the whole range. If first of all, ED50 core is the same, and slopes of the 2 models at ED50 is the same. So we specify parameters, what we are doing. We're specifying parameters of the extended model first. Then we find the parameters of the 3-parameter model. We calculate the difference between the model. And we can also compare to the magnitude of variance error from simulation. That's our error. And you see that variance error is substantially larger than the difference between the 2 models. So we have this difference only on the extreme departures from basic model. And the nonlinearity measures substantially increases for the second model. There is a nice book by Radkovsky where you can read about all these nonlinearity measures. So we decided that it makes absolutely no sense, especially having limited data, to have this more general model for our example. And the conclusions, again, I think main conclusion, we try to integrate theoretical and practical aspects of the project, and these tools are currently under development, similar tools for other studies and other models. And I have to stop, and thank you very much for giving me extra minute.
Quick question or comment or two? Oh, yes. Sorry.
How about ethical approach for this kind of a problem? Would there be any issue in this?
As far as ethical approach, as I said, safety is the top priority.
Yeah, but you said safety, and you start with 3 doses, fixed doses. So
I start.
the first is be very, very little one. It's not up to me to say is it safe or not. But then you have, I don't know, 10-fold or something.
Yes, but we start, the doses which we start with are at the very, very...
It's not an argument for me that it is very, very, because we know about the trial which did have a very, very low dose.
Yes.
6 patients got almost dead.
If something happens with these very, very low doses, a decision will be made. In particular, the trial may be stopped.
Yeah, but if it doesn't happen in the beginning, then you have 10 times higher dose. It's a bit risky approach, I thought, these 3 first doses.
No, the first, no, again, it's a valid question, but from what I heard from PK modelers, they really start with those doses from which they don't expect any pharmacological
Because
effect.
they have enough information.
Yes, so this is really at the very low end, and that's why it doesn't make sense to start any type of estimation starting with these doses. But
James, quick comment and then we should
Could I ask
stop
it differently? Do you have a rule in the, it seems you do not have a rule in the design formally that says, oh, these doses, this dose is too toxic, therefore we have to take other action. That's an external rule, yes?
yes, there is no rule like this in this design.
So formally incorporating toxicity into this regime is a whole other thing.
It's another thing which can be done because the results for two responses, efficacy and toxicity, are there already. And there are papers by Valery Fedorov and co-authors.
It seems that that's what she's
Yeah,
asking
right.
for.
But this was not taken into account for this particular study.
Okay. Good. Thank you very much.